Hi, everybody, and welcome to this webinar. Thanks for joining us today. This webinar is part of the EHMA Webinar series on COVID-19 from viral to containment. The topic today is innovating the management of chronic conditions. I'm George Valiotis. I'm the Executive Director here at EHMA. And in order to make today work really smoothly and easily, we've got some basic rules that the webinars operate by, which is that we mute all the microphones to keep a clear audio channel, but we really encourage your questions and your discussion. So you'll see a Q&A box down the bottom of your screen, and you can put your questions into there at any point, and we are here to answer the questions. As much as we are going to provide you with some information, this is really a place to learn together, to share together. So make as much use of that Q&A box as you'd like, and we're going to make every effort to answer all the questions. We also record these webinars, so if you do have colleagues or you wanted to look back at this later, this will be on our YouTube channel. And we're also live tweeting. If you don't already follow us on Twitter, you'll find us at EHMA Info. So for today's session, we have the great honor of being joined by Lucia Ferrara. Thanks for being here today, Lucia. And you're going to speak about, thanks. You're going to speak about managing chronic conditions amid the pandemic. You're going to look at strategies and organizational models that healthcare organizations developed in the different phases of the COVID-19 pandemic. And then, of course, we'll have a Q&A. So this is my 5-minute overview, and you'll have 20 minutes for your presentation. But a bit more about you is that you're a researcher at Cergas, which is the Center for Research on Health and Social Care Management at Bocconi University in Italy. So I'll hand over to you now, Lucia.
Thank you very much, George, and welcome everyone who is joining to this webinar. The aim of this presentation and of this webinar, as George already said, is to share and discuss with you some of the insights on how to innovate the management of chronic conditions, taking into account what are the learning lessons from COVID-19. So I structured my presentation in 4 main sections. At the beginning, I will give you an introduction of Italy and what happened in Italy during COVID-19. Then I will go directly to the aim and the methodology that we followed during our research and to provide the data that I'm sharing with you. In the third section, I'm going to share with you some evidences on what happened during the emergency to the management of chronic patient in outpatient setting. And finally, we will identify together and discuss some implication to innovate the management of chronic patients. So first of all, if we look at the situation in Italy, the pandemic in Italy, what we discover is that Italy was the first Western country to suffer a major COVID-19 emergency. We had the first case on February 21st, and within 2 weeks' time, there was a massive rise in the number of people who were affected by COVID-19, reaching more than 15,000 cases and more than 1,000 deaths. This had huge consequences, of course, on the national health system. During the first week, there was a massive access to emergency departments, the saturation of ICU and inpatient wards, and many hospitals, especially in northern Italy, had to completely restructure their services in order to accommodate the demand. As you may know, the first wave of the pandemic affected especially the northern part of Italy, Lombardy, where we are located as Cergas University and Bocconi University, Piedmont, Veneto region, basically in the north part of Italy. While now, according to the data published by the integrated surveillance system of COVID-19 that are updated to yesterday, basically, the virus is now circulating throughout the country. We have more than 538,000 cases, and basically there was an impact of the pandemic, especially on the oldest population. The average median age of cases was 51 years old. What we discovered suddenly is that managing chronic conditions amid a pandemic It's proven not to be easy for several reasons. First of all, because elderly and patients with chronic illness were among the most vulnerable population at increased risk of severe illness from COVID-19. As you can see in the image on the right of the screen, the proportion of COVID-19 cases among the oldest population from 60 years old was with severe illness from COVID-19 was higher. And also at the same time, if the elderly and the patient with chronic illness were the most affected, at the same time, the healthcare organization had to balance the need to protect patients and those who live with them from getting COVID-19 with the need to maintain continuity of care to avoid the risk of decompensated patients requiring emergency hospital care. In fact, this required the adjustment to daily routines, the development of new care models, and the need to deal with new obstacles. In fact, the lack of adjustment would have had negative effects on the medium and long term, maybe more important on chronic patients that were not affected by COVID. So, what we saw is that all over Italy, especially in the north, but everywhere, there was some adjustment to the way people with chronic conditions were taking care. So the question that we try to answer is, first of all, what strategies and organizational models healthcare organizations developed in the different phases of COVID-19 pandemic to drive chronic disease management within the outpatient ambulatory setting. And especially, what can we learn from the emergency to innovate the health system and the management of chronic patient? So basically, the aim is twofold. On one side, we had in mind to present and discuss the choices made by several hospital trusts and local health authorities in Italy to maintain the continuity of care in outpatient ambulatory settings. We decided to focus our attention only on ambulatory care setting, as this is the setting that we can find throughout the different organizational configuration. And the second aim was to consider what is needed in the immediate future. Let me tell you that the analysis that I'm presenting today and discussing is one of the chapters of the annual report that we provide as Cergas da Bocconi, that is the Observatory on Healthcare Organization and Policies in Italy. We analyzed 7 case studies in 6 Italian regions. As you can see in the map, they were located basically in the north of Italy, and in those territories that were most affected during the first phase of the pandemic. You can see that there is Lombardy, Piedmont, Veneto region, Emilia-Romagna, Trento, and also Lazio, where Rome is. We selected different cases in order to maximize the differences. So within the case studies, we analyzed hospital trusts, local health authorities, but also research hospitals, because the idea was to understand how different hospital configuration reacted to the same stress test that was represented by COVID-19. We selected, as I said, regions that have had the most impact of COVID-19 in first phases, and with also different models of care delivery for chronic patients, in order to understand if there were some contextual factors or facilitating factors before the pandemic that had an impact on the reaction developed by the single context. Data were collected through interviews with hospital directors, organizational unit directors, healthcare professionals, and operations heads. We decided to focus, as I already said, on outpatient ambulatory care as the common setting to all institutional configuration. but also on chronic patients. The definition that we gave, the analysis was focused on different chronic patient means in terms of people who needed a long-lasting and persistent continuous adherence with the system, and were included, we had a broader definition of chronic condition. We included all the conditions, the most relevant: diabetes, COPD, stroke, but also other conditions that require ongoing medical attention. We divided the time frame of our analysis conventionally in 4 phases. The first that we considered as before the emergency went from the identification of the first case of COVID-19 to March 9th. That was the day when there was the national lockdown. The first phase of the analysis focused instead on the lockdown period, when there was a high number of cases, especially in the north. A lot of people were dead, and that goes from March 9th to May the 4th, so more or less 3 months. Then we analyzed the second phase that goes to the mitigation of the restriction, a lower number of cases, up to the September, when there was a new raising in numbers with new cases. The last part of the analysis, I think, to understand what's happening nowadays when there is a raising on numbers and the new restrictions that are coming into place. Let me go directly to the evidence of this analysis. Basically, regarding the first phase, as I already said, the first phase considered the period from the 9th of March to the 4th of May. What was the situation at the national level? First of all, there was the general lockdown. And secondly, on March the 8th, the Prime Minister ordered a block of all but urgent outpatient services. So only chemotherapy, radiotherapy, or dialysis, for example, were allowed. All other outpatient services were blocked. The third point was that in that situation, there was the definition of the regional network or coronavirus testing center with the identification of the centers. There was also a new involvement of private accredited providers to manage the increasing number of patients with COVID, simply to manage the situation that was really in an urgent situation. And the last point was that during this period, there was the definition of the special continuity care units to monitor the patient at home or in nursing home for elderly. When it comes to chronic patients, what we discovered is that the common aim and strategy of healthcare organization was to maintain the continuity of care at zero risk for chronic patients. So the strategy was to avoid that chronic care patients had to go to the hospitals in order to avoid the possibility to enter into a contact with COVID. Saying that this strategy was similar among the 7 case studies that we analyzed, we identified different actions that characterize the single case studies. So following, first of all, the national rules, of course, there was a block of non-urgent outpatient services, and there was a timely contact with patients. So with different strategies, patients were contacted by the hospital organization in order to block the outpatient services and avoid the contamination. The second action that was put in place was the specialization of the hospital network, dividing, for example, the hospitals in COVID hospitals and COVID-free hospitals. And in these, they decentralized also some of the outpatient services in other settings, especially outside the hospital premises. Where there were some COVID hospitals, the idea was to transform also the internal logistics in order to separate the patient flows and to avoid any contact between COVID patients and non-COVID patients. The fourth action that we saw was the development of digital solutions. During this period, we saw an increase in the use of telemonitoring, teleconsultation, televisit, virtual visit. But as I put it into the slides, often there were domestic solutions, using, for example, the phone instead of Skype or WhatsApp to get in contact with the patient. There were not very structured platform or solutions to develop the digitalization. Many, and I'm going to the fifth action, decided to provide services at home. So in order to avoid the movement of patients throughout the country and to go to the hospital, the idea was to, for those patients who were more at risk of serious, severe also problems due to coronavirus, the hospitals and the outpatient settings, the professionals decided to provide services directly at home. The last action during this phase was the development of task forces to improve the coordination between levels of care, for example, between hospitals and primary care. When we look at the different actions that were developed, what we analyze is that there were some facilitating factors that affected what were the choices made by the different organizations. First of all, where there were previous experiences of collaboration and connection between levels of care, it was more easy to facilitate the decentralization of outpatient services in other settings. Where there was, looking at the digitalization, one of the facilitating factors was, for example, the availability of platforms and previous experiences that were already put in place before the emergency to take into account what were the needs of chronic patients. We saw also a different reaction from the different organizations depending on the expertise of the professionals involved. Where there were previous experiences, for example, of what we call itinerant teams, that means people, professionals that goes also in other premises within the same organization or in other organization, was more easy to facilitate also the decentralization. We at least identified also that the availability of operations management function within the organization was a factor facilitating the contact with the patient, especially the definition of what were the action to put in place during the different phases of the epidemic. If we look at the second phase instead, what we saw was, I'm referring again to the period from the 4th of May and up to September. There was first a mitigation of the restriction, a low number of cases in the first period from May, June and July, and outpatient services opened also to non-urgent patients. The strategy and the aim of healthcare organization was to maintain the continuity and minimizing the risk as during the first phase, while increasing the capacity. So the actions that the organization put it in place were threefold. In one side, there was an increase in the capacity with opening new time, increasing the opening times, the spaces, creating also flexible layout. For example, in Lombardy, in Bergamo, in the hospital of Bergamo, they developed a modular system where in 48 hours they were able to put in place 48 beds for COVID. And at the same time, during the second phase, in 48 hours, they were able to close 48 beds for COVID and to transform them to beds for other conditions. There was, as a second point, also the development of several strategies to recall patients. And the idea was to continue with the decentralization of outpatient service. That was the strategy developed already during the first phase. Moreover, if we look at the digitalization, if in the first phase there was especially something that we called, as I said, domestic, there was the definition of new models of televisit, of regional rules and guidelines, and also framework to sustain, reimburse, and further develop the use of digital solution. If we think that in March, only one region had a pilot project connected with telemedicine, we saw from March onward a development of this solution throughout the country. If in March there were only one region with a pilot project connected with telemedicine, in April we had 2 regions who effectively implemented the regulation and the guidelines on telemedicine, plus 3 pilot projects. In September, almost many regions, for example, there were 12 regions who were already implementing some rules and guidelines regarding the televisit. This is the demonstration that there was a vivid ferment and a vivid transformation on this sense. Going back to what we can conclude from this analysis, similar strategies were developed by different levels. But we saw different level of development and implementation. What happened in the first phase of the pandemic, for sure, accelerated some transformative processes that were already under the radar of healthcare organizations. In the second phase, we understood that there was a learning process and the importance to facilitate the knowledge sharing. Because for those Italian regions, especially in the north of Italy, who experienced the major pressure during the first phase, during these days, so up to date today, they're trying to continue to maintain what they developed during the first phase. While on the contrary, the Italian regions who didn't experience the major pressure during the first phase of COVID are now experiencing the same major difficulties experienced by the northern regions. In terms of putting into discussion the necessity to close outpatient services, the difficulty to do contact tracing, the difficulty to provide swab, for example. We need to imagine a future where we need to fight 2 battles. So COVID-19 plus the need to maintain the continuity of chronic care condition and other conditions. So let me close with some learning lessons. So the management of the pandemic forced us to reflect on the implication to innovate the management of chronic patients. So first of all, we need to think about how to rethink the integrated care pathways for chronic patients. We need to challenge the traditional care models. We saw that the boundaries of outpatient services are becoming more flexible. Many services that usually are provided within an outpatient service are now provided at home. So what do we mean today by outpatient services? Is it linked to the setting or to the activity that we provide? Secondly, we need to develop what we call multi-channel model. That is a mix of in-person and televisit. But we need to discuss on which target can benefit the most from this kind of multi-channel model, when it's feasible, how often we need to put this model into the management of chronic patients, and how to organize it practically. We saw during the pandemic the discovery of the phone, as we saw. There was already the phone, but they discovered the importance to maintain a connection both with patients and with other healthcare professionals. So how we can transform what was developed during the emergency into routine practice, and also to recognize, reimburse it. Finally, we need to develop new roles and competencies. Where there was an operational management function, they were more able to keep in contact with the patient, to recall patients, and to let them know what to do. The second aspect is that we saw a proliferation of digital solutions. We need to move from multiple fragmented platforms to a unified vision and ensure interoperability, but also the security for patients. We need to improve the coordination with territorial actors. In Italy, we saw that the major problem was the link also with the GP, and they developed the USCA as a way to monitor the patient at home. Finally, there is an hypothesis that we need to a new mix of person-centered services and also community-centered services. What was the role of prevention? What was the role of public health? Because we saw that we focused much on patient-centered care, but during the epidemic, it requires a change of perspective also toward community-centered services. And in these, there is also the importance to grant the relationship between levels of care between professionals. Thank you very much.
Thank you very much, Dr. Ferrara. That was really fascinating. At this point, we've got a few minutes left for questions. So if you have any questions at all, please do click on the Q&A. Oh, there is already a question up there. So if you've got any questions, do add them to the Q&A box below. And so we've got a question from John Orvaitvit. Nice to see you joining us again today, John. A couple of questions from you. So can you see those questions, Dr. Ferrara?
Yes, I'm just reading them. So first question is, regards the USCA, do they help patients with long COVID over 3 weeks as slow or no recovery? And second question, in Italy, do you view long COVID as a new chronic condition, and do you have dedicated specialist teams for these patients like UK are developing? Okay, so basically the role of the USCA in Italy that were developed introduced, I would say, in March, was to grant a first contact with the patient, to avoid that COVID patient went directly to the hospitals, because the problem that we were facing was a huge number of people who went directly to the emergency department. And there was a problem of also the GPs. The general practitioners were not able to manage the situation. They had no protection. They were facing a lot of problems with in the interaction with the patient. And so we decided to dedicate this special unit for the first contact, but also to follow the patient over the long term, to monitor their needs and also while they were recovering. So first question is they were helping patients also with long COVID. With the second question, there is a discussion on what to do now, for example, with the USCA. We recognized, because we recognized that there will be a more or less long period of time where we need to live together with COVID-19. So in many organizations, they are thinking if it's necessary to develop a dedicated specialist team like the USCA to continue to take care of patients, of COVID patients also in the future. So I would say yes, there is a discussion in many organizations on what to do also of this special continuity care unit and how they can work also with general practitioners and other specialists. Do you use community health workers from the same community as the chronic patient to visit and support? I would say yes. So I mean, regarding the second question, so if you use community workers, we use them also to support the chronic patient, especially when there were chronic patients also with COVID-19. So there were both problems with the same person.
So Dr. Ferrara, can I add to that?
Yes.
One of the things that I'm left curious about is around acceptability of these changes in service provision. Have you come across any models of how patients are being involved in co-creating the changes in these services?
Yes, there is, in some cases, there were some community building approach. So trying to help other patients that were facing the same problem. This was especially true for those conditions like cancer or rare condition or HIV, that we can consider them also chronic conditions, and where the support from the community, so the other patient, is really important. So where there is already a group of people who is taking care of the same patient, so like patient association, in that case, they were really active in helping the community, so a mutual help.
Okay, and did anything on the workforce come up for you? Like, for example, in the changing demands of the workforce, workforce for chronic illness, were they diverted to COVID responses? Was there anything that came out about that?
Yes, regarding the professionals, what we saw was that, especially in the first phase, all professionals were devoted to COVID. So we saw a despecialization if I can say like that. So also professionals who were specialized in other disease, they were devoted to the COVID-19. After that, we saw that depending on the institutional asset, also the organization, in the second phase, they were trying also to have more professionals because there was a lack of professionals available to take care of patients. So this was a huge problem. The availability of human resources and professionals was one of the major problems that we had in Italy. Absolutely.
And are there any sort of indications of how the workforce education will need to evolve as we keep walking into further unknowns?
Oh yes, of course. We need to think how now the professionals need to take into account what is the role of the different professionals. And now we can involve not only the specialists that we already know, but also give more responsibility, for example, to nurses. And now there could be a skill mix, and the nurses can support the clinicians in calling the patient, doing a phone follow-up with them, and to understand how to avoid that they are left behind, because this is the most important problem in this moment.
You did reference the way that integrated care needs to be revised and rethought. And I wonder, in the Italian experience, given that you have different limitations on what your pharmacies can offer, have you seen a changing role in pharmacy as the continual face-to-face place where patients and citizens can interact?
I will say not yet, but this is something that we need to invest on. The role of pharmacy at the territorial level also as the first point of contact with patients. They need to be, they need to have some support also to act in the territory where they are spread. They are almost everywhere. I would say pharmacy, but also the role of GPs.
Yeah, indeed, indeed. Dr. Ferrara, I want to ask you so many more questions, but I know we need to wrap it up. So if people do have any other questions for you, we're going to put all of the information that you've put on our website, and we will email that link to everybody who's registered. Plus, you can review this on YouTube if you wanted to check that out there. And you can also you follow us on social media. So if you have any questions at any time, also when you close this this webinar, you'll get a little survey to ask about your feedback, and we really value that. John Oretvit, who was asking some questions, is someone who's already provided us with a webinar. So if you wanted to see that, that's also on our YouTube. And we've got another presentation that was done by Dr. Americo Cicchetti from Sacré-Cœur about in Italy, looking at the different regional responses of Italy. So there's lots of really interesting content there if you wanted to see other things that might inform your learning today. And if you do want to be part of a bigger conversation about health management, do join us at our conference on the 17th to 19th of November. You can register at any time to do that, but you want to get in soon. And if you're actually interested in being a conference rapporteur, we have a dedicated program on conference rapporteurs. So do get in touch with us if you're interested in that. Now, I do see a message, a note from Annalise. Hi, Annalise, nice to have you with us today. What you found interesting is the issue of person-centered care for COVID patients. Yeah, absolutely. Absolutely. And I have one last question for you, Dr. Ferrara, and then we'll close up, which is the idea of non-urgent care. And so non-urgent needs were being diverted. I'm guessing that how that's classified will have to be revised over time, and that what appears non-urgent initially, that with chronically unwell people, you know, those things might increase in urgency despite not initially looking urgent. Did that come up about how classification will be done?
Yeah. So the classification of urgent and non-urgent care was based on work that the Ministry of Health did some years ago in defining the the ambulatory care in different levels. So they already had a system in place when there was the definition of urgent care as a priority A. And so they need to have a meeting. So they need to provide a visit in 2 days, more or less. Then there is the level B. There is a brief So I mean, is shorter term, and there is non-urgent. So in the definition of what was urgent and non-urgent, of course, is a matter of definition. We can agree or not agree, but this was a work that the Ministry of Health already did in the past, just to put in under observation the levels of care. So the standards of care and the minimum standards that we need to grant all over Italy. So they defined according to that also what was urgent and what was not urgent. But what we saw, and I'm totally agree with you, that when it comes to chronic patient, the definition of urgent and not urgent is a matter of discussion. In fact, what was most interesting for us was analyzing what could be the impact in the short, medium, and long term for chronic conditions. Because we don't know yet how many people died during these months, not because of COVID, but because of other conditions that were not well managed. So we need to take this into account and under consideration for the future.
Those are great sort of final comments. Thanks very much, Dr. Ferrara. I really appreciate your time and the really important good work that you're doing with your colleagues there at Bocconi. Thanks so much for joining us. And thanks everyone who joined us today. I also appreciate your good and important work. Thank you for being part of this community of practice of looking after Europeans' health management. Hope to see you at our conference and otherwise at our next webinar. Take care and see you soon.